Hi guys, this is Jody. This is part 2 for perfusion and coronary artery disease. You guys should have already viewed the first video, which was part 1. And so now we're going to jump into more clinical manifestations. So again, you can be working in any type of setting and end up caring for a client who is having a myocardial infarction. Because like I said before in the first presentation, it is often the first sign of coronary artery disease. So recognizing those risk factors and teaching prevention to all clients, regardless of clinical setting, is important. You'll discuss more about dysrhythmias in 222, but again, you should be able to recognize ST elevation MI, as well as for 212, normal sinus rhythm, and atrial fibrillation. So we will talk more about pump failure, heart failure symptoms when we discuss heart failure in this course. But right now I want to talk about pericarditis and Dressler syndrome. So pericarditis is inflammation of the pericardial tissue surrounding the heart. It is a complication that can occur after a patient has a myocardial infarction. You can recognize this by the symptoms. Pain can be aching, sharp, or stabbing in the chest, but is generally worse on inspiration. So if you think of the lungs expanding when you take a deep breath or you breathe in, it pushes the heart up and forward, which actually pushes the heart up against the sternum if there's inflammation there. Okay, so if it's inflamed, you can hear a friction rub when listening to the heart sounds. So pericarditis is often treated with anti-inflammatory medications, which would be ibuprofen, or you can use corticosteroids if it's more severe. Now, you can have a patient coming in with pericarditis that has nothing to do with the patient having had an MI. Their, diagnosis might be pericarditis, post chest trauma, or, maybe they just underwent some kind of surgery in the chest or something like that. They can end up with pericarditis. The telltale symptoms of pericarditis are going to be chest pain that worsens on inspiration and that pericardial rub. Because itis, it's an inflammation, we are treating with anti-inflammatories. Okay? We will talk about tamponade a little bit later on. And tamponade is different. Tamponade is life-threatening. So you guys need to be able to differentiate pericarditis from tamponade. And I know for sure you'll talk about tamponade in 222. Dressler syndrome is thought to be an immune response, and it may reoccur for several months after a patient has had an MI, and it generally resolves on its own. It is characterized by fever, chest pain, and dyspnea. Because it also involves pericarditis, you might hear a friction rub when auscultating heart sounds. If the fluid buildup, that pericardial effusion is severe, they can do a pericardiocentesis. So they can stick a needle in there and draw off some of that fluid. Another treatment, so if you have a patient who's admitted with pericarditis and it's pretty severe and anti-inflammatories aren't working, they can do a procedure called a pericardial window. So they can do a little cut in the pericardium to drain that fluid out into the chest cavity. So there are treatments for pericarditis. So Dressler syndrome can include that pericarditis, but you also have that ongoing fatigue and weakness and fever, kind of ongoing chest pain, that type of thing. So I have the think outside the box image. This is just a reminder to think of the impact the heart has on the rest of the body. Okay, if the heart is not working properly, it may not be able to perfuse effectively. The skin is going to feel cool and or appear pale, so this is a sign of decreased perfusion. Capillary refill time may be prolonged because it will take longer for blood to travel. Okay, the brain requires a lot of blood, so if not perfused properly, we might see changes in level of consciousness or cognition. The client may be lethargic or confused. And if perfusion is impaired over a long period of time, we may see a decline in kidney function. So we have to think about all of those other things and not just the heart. Okay, again, we talked a little bit about this prevention and management in the first video, but we want to teach smoking cessation, manage blood pressure, strive for a healthy BMI, manage cholesterol and diabetes, encourage activity. So the American Heart Association suggests 30 minutes a day, 5 to 6 times per week. Teach stress management, provide diet teaching. Again, we want low cholesterol, low fat, high fiber. They can get that fiber with lots of fruits and veggies, that type of thing. Let's see. Lean proteins. Pay attention to women who have risk factors and are taking oral contraceptives. Okay, especially if one of those risk factors is smoking. Once a client has been identified as having coronary artery disease, which is usually diagnosed after the patient is having a heart attack, the goals are to manage the pain, reduce the cardiac damage, maintaining cardiac stability, decreasing cardiac workload, and preventing complications. So there are many areas where collaboration will occur for clients with CAD. So let's start on a med-surg unit when the client develops chest pain. And we can think about, who is involved. I will have a video for you guys in class of a rapid response for an MI. So I think I talked in the first video, you have a patient who's out in the community, they have chest pain, they call 911, the paramedics come, so there's collaboration with the paramedics and the hospital. So the paramedics identify by doing an EKG or putting, the monitor on the patient. They can see the patient's having ST elevations. They will in turn notify the hospital, which then, has an MI team response. So you have nurses and doctors and techs, involved in taking care of this patient. So there's a lot of collaboration there. And then you may have a collaboration, maybe the patient goes into the cath lab and they decide the patient has multiple blockages. It's going to be safest if they go in and have coronary artery bypass graft, which we'll talk about in class. Then you have surgeons involved. You have the cardiologist involved. You're going to get the primary physician involved. There's a lot of teaching that takes place when a patient has coronary artery disease. So the more collaboration to cover those bases, the better. And it provides good support for this patient. The diagnostic tests that you guys want to be aware of, and there's a number of them that the book notes. The big ones for 222 are going to be the EKG, identifying if the patient is having an ST elevated MI. The troponin. Is the troponin positive? Now, you can have patients who have positive troponins for other reasons. That might be rhabdomyolysis. Maybe they came in after having a heart procedure, like, maybe they had CAD, they came in, they had stent placement, they go home and they have this continued chest discomfort. Maybe they have Dressler syndrome that hasn't been diagnosed yet, and they come in and they have positive troponins. Well, their troponins are still going to be elevated from the previous time. So there are reasons that a troponin might be elevated that's not indicative of right now the patient is having an MI. We want to look at that. We're painting the picture, putting all these pieces together. It's like a puzzle we're putting together to say, yes, all of the pieces fit to show that, yes, this patient is having an MI. When we have patients who are either that we're looking at risk factors or, the patient has had an MI, we want to identify what are their risk factors so that we can start treating those. We look at cholesterol screening. We can look at an echocardiogram, which is an ultrasound of the heart. So, if a patient has undergone treatment, after an MI, so they've either gone to the cath lab and had a stent placement, or they went to the cath lab and they decided the patient needs to have open heart surgery, we can do an echocardiogram after these procedures to see how well is that heart functioning. We want to look at that ejection fraction. So a normal ejection fraction is going to be right around 60 to 70%. That ejection fraction is the percentage of blood that's being pumped out of the heart each time that heart beats. You get that contraction. It ejects blood. Okay. Wouldn't be 100% because if you think about the heart squeezing together, it would have to completely squeeze 100% together to push out 100% of the blood that's in the heart, right? So it pumps about 60 to 70%. An echocardiogram can determine what is their ejection fraction. So when we start to see heart failure symptoms, and we'll talk about this more when we talk about heart failure later in the semester, is usually when they get to under 30%. Conservative management. So if you think about conservative management, it's the the most minimally invasive things that we can do. So first, we're going to start out with a patient and manage their risk factors. So we're going to say, if they smoke, stop smoking. If their diet is poor, we're going to teach them a heart-healthy diet. If they have a sedentary lifestyle, we're going to get them up and exercising or on an exercise program. If they're hypertensive, we want to make sure that we're managing that. If they're diabetic, we want to manage that. So that's how we conservatively manage. The next step would be adding medications. The next step after that might be doing procedures like stents and stuff. But the most conservative is to really modify their risk factors through healthy living, okay? Healthy diet, exercise, that type of thing. Smoking cessation is huge. It reduces the risk by 50% within 1 year of quitting, okay? It may also improve cholesterol if they stop smoking, okay? And it reduces, when a person smokes, their blood becomes thicker. So smoking cessation reduces the blood viscosity or stickiness, okay? So the blood is going to flow better if they're not smoking. So when you think about this, if you yourself are a smoker, if you know somebody who's a smoker, you will often have them say, I'm not going to quit smoking. I'm never going to quit smoking. There are motivators and ways that you can get patients to stop smoking, okay? And, I always tell patients, okay, this is not what you want to do today. Let's target some other risk factors, but we are going to come back to this because it is very beneficial for you and for everybody in your household and everybody around you if you stop smoking. So I never let that go. I am a nag when it comes to smoking. And so I do stick with patients with that, but I don't judge them. There's no judgment. I don't judge a person for smoking. Addiction is real. It is something that people become addicted to. So I do, come at that with a way that is understanding. Okay, zero judgment. But I will nag, and I tell them right up front, I will nag about the smoking. Diet. Okay, so fresh fruits and vegetables, avoiding processed foods. Lean meats are good. Okay, so chicken breast, fish, lean beef. We want them to be eating fiber, so oats, fruits, vegetables. Instruct clients to avoid foods high in sodium and avoid adding table salt to food. Okay, so we know when we eat salt, okay, water follows salt. So if you figure that a patient's eating a lot of salt, they're going to add water into their vascular space, and that actually increases workload on the heart. Okay, we don't want that to happen. We want to reduce workload on the heart. Okay, so low salt is better. They should be getting their carbs from fruits and veggies and grains and avoid processed foods like canned, frozen, packaged foods. And then the book states ETO in moderation. But how do some clients define moderation? Okay, so we have to think about that, especially because some people will say, well, red wine is good for your heart. I drink 2 glasses of red wine a day. Well, is that in moderation? Who defines that? So you really have to get a true picture about what this patient is doing, how it's affecting them. It's going to be a little bit more individualized when you talk about that stuff. Exercise 30 minutes a day, 5 to 6 times a week of moderate intensity. So we want them getting their heart rate up into that aerobic zone. For weight loss, they can go up to 60 to 90 of moderate intensity exercise daily. And I always tell patients too, like if they are trying to lose weight, and everybody's different, BMI, I actually hate the BMI scale to be 100% honest, because you can have some patients, if you just look at BMI, that would come across as obese, but they might have a very low fat percentage. So you have to look at a patient individually. So the BMI I just use as a little tool. You can kind of see if a person has, more fat than they should. We come at that. And we have to be very, weight is something that people, struggle with. And so we have to come at that with compassion too. That I always tell people too, that weight loss happens in the kitchen. The exercise is something that will help you burn calories, but it often is something that makes you hungrier, right? So we have to balance that with what they're eating. So if they can combine the healthy eating with exercise, that is the best combination. Manage hypertension. So lisinopril, your ACE inhibitors are the biggest drugs that you're going to see for high blood pressure. We can also have them reducing their sodium intake. Regular exercise is going to help with blood pressure. Stress management helps with blood pressure. And then any medications. So they could be on diuretics, they could be on beta blockers, calcium channel blockers. We know there's a lot of different classes of medications that treat blood pressure. So we want to make sure that they're taking their blood pressure meds as prescribed. Diabetes management. So if they are diabetic, are they checking their blood sugar regularly? Are they taking any blood pressure medications as prescribed? So that's really important. So pharmacology, I gave you guys a very comprehensive list for perfusion. You can use Pharm Made Easy, has a cardiovascular medication module that is fantastic. I know I give you guys so much prep work and a lot of optional stuff to look at, but I do think that it's very helpful to go through those and understand the medication. So review the med list given. Do not focus heavily on 1,000 different side effects, okay? So if you look in Pearson, has some of the medications listed. They do a good job of kind of identifying what are the biggest things. What does this medication do? You want to know it in very basic terms. Like if we're talking about statins, we're targeting the LDL. So we obviously want to be, looking at their cholesterol levels. It also impacts the liver, so we'd be looking at that. We know that statins can cause some rhabdo-type symptoms, so we would be looking at, are they having new muscle weakness? Those are key things with statins. Really, that's about it, okay? When you talk about beta blockers, we know that beta blockers lower the blood pressure. If we're dropping somebody's blood pressure, we know that we can put them at an increased risk for falls if they get dizzy, right? So we're going to monitor for dizziness. We're going to teach fall prevention, sitting up slowly. We're going to be monitoring their blood pressure. We know with beta blockers, they're going to lower their heart rate. So we better be looking at their heart rate too, okay? Those are the main things I want you guys to be focusing on, okay? Let's see. Drugs that treat angina, the nitroglycerin is huge. That is a big drug. I can tell you right now, I'm going to test you on nitroglycerin because it is the key drug when it comes to angina and chest pain, okay? It vasodilates, okay? Because it vasodilates, you can have a patient get a pretty nasty headache when they take nitroglycerin. How do we know if it's working? We are going to ask the patient before we give that nitroglycerin, what would you rate your chest pain? After we give it, we're going to say, what would you rate your chest pain? Okay, so those are things that you need to be thinking about when you're thinking about those drugs. So I gave you the form. It is the same drugs that we're going to talk about with peripheral vascular disease, the same drugs that we'll talk about with stroke, okay, and heart failure. So those are the meds for all of the stuff that I teach under perfusion, okay? Big ones, like I said, for CAD, we have to manage blood pressure. We have to manage cholesterol. We have to treat somebody who is having an ST elevated MI. So we'll talk maybe a little bit in class, but if I don't, I'll say it here now. There is an acronym that you guys, they may kind of go through this in NCLEX, and it's MONA, M-O-N-A, MONA. And it's morphine, oxygen, nitroglycerin, and aspirin. Okay? And that is something you might see somebody treated with if they're coming in with an MI. Okay? So we know that they're having pain, the morphine, which some of the hospitals are getting away from the morphine a little bit. But if you think about what it's doing, yes, it treats pain, but it also vasodilates and reduces workload on the heart. Okay? So we can give that oxygen. We want to support the heart muscle. Nitroglycerin is a vasodilator. We want to open the vessel as much as we can to try and get perfusion to the heart. And then aspirin is your antiplatelet. And we'll talk about more. There's integralin, and I can never say the generic name for integralin, but it's the apetafetabetide, something like that I have on there. There are other antiplatelets, so we look at antiplatelets. You might, if you're in a remote area where there's no cath lab, you might be giving that thrombolytic TPA. Okay, so look at your drugs, look at that drug sheet. Again, try to focus on key elements of those drugs. Don't write down every single side effect. We want to think about what are we treating, How do we know if they've had a therapeutic response? What are the biggest, most life-threatening side effects that the patient can have from these medications? For example, we give TPA, the most threatening side effect is going to be bleeding, okay, profuse bleeding, that type of thing. Okay, you guys, so that is it for the going over the CAD exemplar. You should be utilizing your, Pearson book to go through this stuff, utilize your student learning outcomes, and when you come to class, you guys can ask me any questions about this stuff. We'll go over it, but we are going to be focusing on revascularization. So it's going to be, angioplasty and coronary artery bypass graft and the nursing considerations and complications that go along with those. Okay, so I will see you soon. I know that it's a lot, but we kind of start you guys out with this perfusion stuff because we know that you guys are just geared up and ready to go. So I look forward to seeing you guys. Thanks.